Good morning. I'm Dr. Karthik Raj from India. Today we're going to see the knee examination for academic point of view. Here is Mr. Kumar, who would be our patient to conduct this knee examination. Mr. Kumar, I'm going to examine your knee for academic purpose.
Yes.
Thank you so much. Starting with the knee examination, I would always like to have my patient in standing posture first so that I can have a quick look from the front, side and back, and also do a dynamic examination. From the front, I would always make my patient stand erect like that so I can see any ligament discrepancy. I could also see if both the patella are at the same line, any obvious swelling, and even have a good glance at the hip, knee, ankle alignment, the normal to the valgus angle of the knee, and also looking at any gross swelling or bony lesion that's seen on outside on and around the knee. The second thing is that I go around the knee 360 degrees, starting from the front, from the side, and also I have a quick look at the popliteal fossa, the leg, the calf muscles, and also the calf muscles, and also the back aspect of the thigh. The other thing I would like to do is to make the patient take a few steps of walk. Yeah, back please. This way. So by this way, I also see a look into the gait analysis, whether his stance and swing phase are normal or any neurological involvement. Of course, in this case, everything works out to be normal. And the other quick examination, especially concerned with the knee and the hip, is that I make the patient to do for a squat. Can you please squat like this? Yeah. So this is a clear show that we're going to stress the hip and knee joints, and it's going to give an overlay. If the patient is not able to squat, it could also be a problem from the meniscal injury of the knee and also to do something with the hip. So this is quick analysis of the hip joint. The second thing, of course, before going to the examination, which I had not mentioned earlier, I would like to have a clear history from the patient, which I'm not going to talk so much because here we're concerned only with the examination point of view. So going to the other part of the examination, now I would like to make the patient, see the patient in supine position. So could you please lie down? Here. You can lie down, yeah. So I would see to that the exposure of the patient is adequate. That's really important, especially the patient is exposed even till about the knees, and he's in a very comfortable position for my examination. Having a look from the start of the patient, seeing the inspection, again I do the same thing that I've done in the standing, starting from any ligament discrepancy, any wasting, muscle wasting that is noted, comparing the levels of either levels of patella and the medial malleolar line. Here in this case, everything seems to be fine for me as part of the inspection. There's no evidence of muscle wasting. The calf muscles appear the same on either side. The quadriceps looks the same. Patellar portion in alignment. And even this gives me a good view of any rotational deformity of the hip, because both the patella are slightly external rotated and facing upward. Similar on either side, which gives me a good lay. Starting, before going to the knee examination specific, I would like to finish a quick look of one joint above, one joint below, which I simply do with the hip joint first, asking the patient to do an active SLRT. Can you please lift the leg straight? Yeah, straight please, yeah. And he's able to do that, so that clears it out. And quickly, I take the patient to check for the rotations of the knee, rotations of the hip joint. And the second thing, I take it to the figure of 4 position, because this clearly rules out there's no any rotation deformity, and also rules out any sacroiliac joint pathology of the hip joint. And then I take it to all degrees of extreme hip movements. Take a log roll or movements are fine and not painful, so there's going to be no issue with the hip joint. And looking at the ankle, there's no swelling or any deformity. Obviously, the ankle appears to be inside plantar position. And going with the movements, I quickly go with the flexion, plantar flexion and movements, which seems to be fine to me. Yeah. Now let me go to the knee joint in specific examination, starting from inspection. So looking at the knee joint, I start with any obvious swelling or obliteration of the space around the patella, the peripatellar brace and the supraspatellar brace. In this case, it looks both fine. Again, the swelling confirms there could be an effusion, either intra-articular effusion or in which case the patella appears free. Surrounding the patella, there will be swelling, which we commonly describe as the horseshoe-shaped swelling. Of course, if there is a peripatellar bursitis, the swelling is going to be superficial to the patella, which is going to be very clear on inspectory point of view. And the second thing I see is the evidence of muscle wasting, which I talked about in general examination, so I'm not going to waste time on that. So going to my start on palpatory findings, I'll start with the palpation. I can start from either way going around. So I start superficially, which is the common standard teaching, any joint want that's seen here, because going on with the other examination, we might end up having frictional effect on the hand. So I start with the checking up the want first, and then I see if there is going about to see any bony tenderness or joint tenderness. For seeing the tenderness of the joint, I don't really ask the patient. I have a look at his face and see if the patient is going to wince on pain. I start with the tibial tuberosity. Any pain here? No. Of course, at this age, you gotta check osteochondritis lesions of the patella, also the tibial tuberosity. Starting from the tibial tuberosity, I run my hand or fingers on either sides of the shin of tibia, slightly going to the first tip. So I have completely palpated the proximal tibial bony spots and ended up going to either side of the joint spaces, the medial and the lateral joint space, and seeing for any joint line tenderness. And do that, I usually get the knee to 30° of flexion, and I could feel my fingers peeping into the joint, so that's very clear. So the significance of joint line tenderness is starting from which could be osteoarthritis or even a which is more sensitive in meniscal injuries, especially the peripheral horn meniscal injuries, and also the collateral mid-substance injuries, which on the medial side is going to be the MCL, on the lateral side is going to be the LCL. After finishing that, I go to the distal femur again. So here the medial femoral condyle, lateral femoral condyle, and now tenderness on this part. And then I come to the anterior aspect of the knee, which is the patella, and now patellar facet tenderness, both on the medial, on the lateral aspect of the joint. Then I go to check any patellar effusion, intra-articular effusion, by doing a patellar trap, whereby I try squeezing all the fluid from the suprapatellar pouch, synovial pouch, and then try trapping on the patella, which is obviously negative here, to check for, this is of course to check for any fluid conduction inside the joint. Then starting my examination quickly with the patella, I go ahead, of course, in the history. If I have any history of patellar dislocation or recurrent dislocation, I go ahead on the patella, doing an apprehension test and a patellar stride test. On the slide, I slide the patella on either ways. Especially we're going to have a lateral patellar subluxation with MPFL injury in most recurrent cases. So I slide the patella rightfully and see the quadrants of slide. Usually should not cross the midline or try to subluxating. It's not happening here. And then I do the apprehension test, where I keep the patellas pushed to the lateral aspect with my finger and take it to slide 30° flexion, try subluxating, and have a look at the patient's face if he's kind of having any pain or apprehension. Yeah, in this case, he's completely fine. And now going to the special examination of the knee, I always split the structural ligamental examination of the knee, starting from outside in. So outside, I feel the two main structures are the collateral ligaments on either side. So having the collateral ligaments, Starting from the lateral collateral ligament, we go for the varus and valgus stress test. So I do the varus stress test first. So the varus stress checking for the lateral collateral ligament. So I do the varus stress in 0 degree, that is in complete extension, and also at 30 degrees of flexion. The same way I repeat the valgus at 0 degree and 30 degree of flexion. So the significance of 0 and 30 being complete extension is going to check if you're going to free the snap up or opening. It shows the not only the collateral, also the anteromedial or the lateral complex in either cases. But doing the stress test at 30 degrees confines it to the isolated collateral ligaments. Then quickly going to the intra-articular ligaments, that's the anterior cruciate ligament. I go with the I tell the patient to leave the knee loose, and then first start with the Latchman's test, which I do in knee in 30 degrees of flexion, making the patient feel free with my hand holding the distal femur and proximal tibia. I try translating the tibia over the femur and check for my translation, point number 1, and the other point I check is the end point that I feel. Usually hard end point is very indicative of good intact ACL, and a mushy end point is sure of an ACL tear. And before I do that, I always see the tibia as at first in neutral position, and then I pull it anteriorly. At the same time, I can also do a posterior attachment, checking for the posterior cruciate ligament. Then I go ahead, taking the knee to 90 degrees of flexion, and then do a Latchman's test, an anterior dorsal thrust, wherein I take the knee to 90 degrees of flexion, hip and 45 degrees of flexion, both my hands behind the knee, palpating the hamstrings to see the medial and lateral hamstrings are in relaxed position. My thumbs on the shins of tibia on either side, and my tip of the thumbs plunging into the parapatellar joint space. And now, keeping the tibia neutral, I try pulling it anteriorly and see for the translation. Of course, the normal translation is going to be less than 1 centimeter. Anything beyond that, and I compare this on the other side, anything beyond that is going to be graded in grade 1, 2, 3 based on 5 mm, 5 to 10, and more than 10 to 15 mm in translation. The same way I do the posterior Latchman's either. The third intra-articular structure being the menisci. The point number 1 I see for menisci is going to be my joint line tenderness. The other one I see is the McMurray's test, wherein I flex the knee completely and take the foot to external rotation and see for medial joint line tenderness or flick by taking it to kind of an extension from flexion, and do the other way around by internal rotating and palpating the lateral joint space for the lateral meniscus. So it's external rotation for the medial meniscus and internal rotation for the lateral meniscus, and from flexion I take it down to extension, and I see the point of tenderness of the flick. If it's very at high degree of flexion, it's going to be a posterior horn, and slightly in the middle it's going to be a middle horn, slightly more it's going to be an anterior horn kind of a tenderness. And finally, not only I always take the patient to make the prone position or slightly lateral and see for the popliteal fossa, and also I check for the IT band friction syndrome like the overs. I take the hip to can you please say that in the lateral, and hip to for a little bit of abduction and extension, and leave it down. If there's going to be any tightness, it's not going to drop. And also I check for the friction syndrome like the Nobel's test by flexing the knee from extension and keeping a hand over the lateral femoral condyle and checking for pain or friction or snapping of the IT band. At the end, I see for the sensation and neuromuscular involvement by checking for the dorsalis pedis and the posterior tibial. I ask the patient to can you please push it up? Yeah, hold it tight and pull and see, and push it down. Can you push it down? Push it down. Yeah. And stress for strength, and compare the sensation. Is it same on both sides? Yes. I check for the sensations. So completing the overall knee examination. There's a number of other tests either, especially for the meniscus, which is a sensitivity Thessalys test, wherein I make the patient squat like this, the patient squat, and kind of a duck walking test we can do. I think this would cover the basic examination. Thank you.